afternoon, everyone. Thank you so much for joining this session. This session is supported by Abbott. Thank you so much for your huge support. And over the next hour, we will be talking about maximizing the potential of MitraClip. As you know, the mitral TEER approach is the first-line therapy of the transcatheter approach for the significant MR patients. And we are fortunate to have a bunch of experts here on the panel. And myself is Yohei Ono, interventional cardiologist at Tokai University Hospital. I'm so delighted to co-chair this session with my great friend Paul, who came all over from Minneapolis.
Yep.
From minus 30 degrees to maybe 3 degrees?
Above freezing now.
Okay,
That's all that matters.
So you feel quite warm now.
Yeah.
And we have a crew of imaging specialists and interventional cardiologists, so we will deep dive in this field. So as you know, this MitraClip therapy is supported by huge evidence, both from the randomized controlled trial to the registry. And we will start this session by overviewing the evidence we have right now. So I would like to introduce great friend Makoto on the stage to give us a talk about the clinical data. Makoto.
Thank you, Yohei, and it's my pleasure to talk about my present talk about the Ocean Mitral Registry. This is the Japanese registry that has been started, and we have been publishing a lot of data, so I'd like to introduce a couple of these data. These are my conflict. So Ocean Mitral Registry is a prospective multi-center observational study that includes more than 3,700 patients, includes gathered by the 27 institutions. These are the members, and more importantly, they are smiling after hard work. So the number of published papers has been growing. Left hand is a co-op trial. They have published a bunch of papers, 50 papers during the 7 years. Our Ocean Mitral Registry, within 2 years, we have published more than 13 papers. So let me introduce a couple of the results from Ocean data. 30 days and 1 year outcome from Ocean Mitral. As you know, in the early days, we have used only NT and TW, and with only limited device, we have a high APS rate, less than 2, comparison to other trials. With the 1 year data, we noticed that as the other registry, primary mitral regurgitation should be less than 1+. More importantly, in the secondary MR, reduction of the MR less than 1 is have a superiority comparison to the 2+. Which means that the MR +1, less than +1 is required even in a functional MR. What about the MVA and the clinical outcome? Although, as you know, Asian patients have a small size, body size, and also they might have a small annular mitral valve area. We look into the 1,700 patients and divide it into 3 groups. Group 1 is MVA less than 4, group 3 is over 5, and group 2 between. And importantly, the death hospitalization, all-cause death, and heart failure hospitalization did not change within these 3 groups. And interestingly, if we divide this group 1, MVA less than 4, into 2 groups with MVA less than 3.5 and over 3.5, very small MVA and small MVA did not have any difference between the between those 2 groups in death and hospitalization, all-cause death, and heart failure hospitalization. So no difference in outcome after MTEER, even with a very small MVA. This is very encouraging data for a small MVA patient. Let's go into the residual MR and LAP pressure. If we look into these mitral regurgitation, residual mitral regurgitation, and left atrial pressure post-procedurally, Optimal result, obviously, is post-left atrial pressure less than 15 and residual MR less than 1. Poor group, as you can imagine, left atrial pressure over 15 and the residual MR over 2. But there are some patients with a mismatch. Sometimes some patients have a left atrial pressure over 15, although their MR is less than 1, other than vice versa too. And we look into the data, we noticed that one-third of the patient are mismatched patient, and within that mismatch, two-thirds have a post-left atrial pressure over 15, even though the MR is less than 1. And look into the outcome with these patients, the mismatch group seems to be a similar prognosis comparison to the poor group. This is very important. Even though you are treating with the MR, if the left atrial pressure is high, the outcome seems to be similar to the poor group. So mismatched patient with residual MR over 1 or high left atrial pressure had a poor prognosis as left atrial pressure, rising resting pressure, and residual MR. These are the risk factors for mismatched group, and you should read this paper. It's a really important paper. Also, there are patients in LVEF is worsening after the TEER. That is, has been shown in a surgical group, but what about in TEER for primary MR? Notice that there are 32 patients, 32% of the patients who demonstrated a decrease in LVEF, and those patients did have a similar degree after the mitral TEER. The reduction of the degree in both groups had a similar reduction. And what about the outcome? The all-cause mortality, heart failure hospitalization did not change even though the worsening heart failure patient, worsening LVEF patient. This is very supportive. Even though the LVEF is reduced, the prognosis seems to be similar. What about the cardiac damage and the frail? This has been shown in the European and US data, showing that similar data has been shown in our registry as well. Poor prognosis in a cardiac damage patient, and the poor prognosis in high frailty patient. Notice that there are the similar accumulation of the mortality, even though there are MR was reduced to less than 2. If the clinical fatalities goes up, the chance of the all-cause death is rising. Finally, the prognostic impact of being underweight has been shown in this paper, which is very interesting for the, especially in Asian country. There are 21% of the patients were underweight, BMI less than 18.5, and looking at those prognosis, the underweight patient have a poor prognosis compared to normal or overweight patients. So these are underweight patients. Before TEER is a poor prognostic marker. So the take-home message, the procedure result from mitral registry is comparable to Western registry. Asian population have a different background and anatomy, and outcome may differ. More new evidence of TEER is coming from mitral registry. Thank you very much.
Thank you, Makoto, for highlighting the early results from the Ocean Mitral Registry. So we learned a lot from this study regarding the patient selection and how to optimize the outcome of each patient. So Paul, I would like to first ask you about how can we integrate these results to our clinical practice to offer the best outcome for the patient?
Well, first of all, congratulations on the incredible amount of data and publications that you've derived from this registry, which just started a few years ago. I think it's really quite remarkable to see the insight, as well as the high level of procedure success, despite having mainly NT and NTW. I can only hope that your results will get only even better with more G4. So congratulations. I think it's a great foundation that you're starting from. It's really nice to see a lot of the analyses that are being done to help guide what might be seen from a prognosis. I think knowing about frailty, knowing about some of the things that guide the prognosis when you're discussing with patients, what to expect from the procedure is really important. There are several studies that have also shown left atrial pressure elevation and the mismatch being related to outcomes. We saw that in our hospital as well as others in the United States. So that speaks to the need for medical therapy, for example. And so these studies are really important, and they really help us give the insight into how we can impact our patients.
Exactly. So since we have using the G4 system, we can monitor the pressure of the left atrium through the guiding catheter. So in your clinical practice, Professor Hom, do you utilize this left atrial pressure monitoring as one of the endpoint of the outcome, or basically you heavily rely on the echo outcome?
Actually, it's very good, great data, because even successful result, higher LA pressure is associated with a poor outcome. So that's why I don't believe LA pressure that much. So because LA pressure can be affected by various conditions.
Sure.
LV function and the high LA pressure, residual MR or stenosis, all the factors can be, affect those LA pressure, higher LA pressure.
Thank you.
So we usually believe echo.
Echo, okay.
Because I'm user.
From the echo expert. Very reasonable answer. Okay, so KK, same question to you.
Yeah, we looked at it for a while, the LA pressure, but for a variety of reasons, I think as Dr. Hong mentioned, we have stopped using it. The new G4 fortunately has that transducer, which is quite helpful. But we look at the pulmonary vein flow as and other metrics of MR reduction as more important. I think the data from the Incredible Ocean Mitral Registry is definitely informative. But in this case, I think there are other aspects which I think have been more important. Can I ask a question?
Sure.
What is the experience with the number of clips in practice as the sites in Japan gain experience? Could you all comment on how many clips are used at all from your experience? Thanks.
Makoto.
Well, I can't say the exact number, but it's around 1.1 to 1.2 clip number all total, including the G4 device.
Thank you. So any other comments, questions, or feedback from the audience? We're waiting for any kind of comments, so please don't hesitate to do so. So Chris, we talked a little bit about our patient selection and outcomes. So we find similarities and non-similarities among also the Asian populations. So do you find any difference for your patients that we treat?
Yes, thank you so much. You did a fantastic job to get the data from the Asian country. So now we have the evidence for the Asian people. So I would say the Asian patient, the valve area is smaller to compare to in the Western country, and also the left atrial size smaller, and also the body weight is smaller. You have the answer for us. In the past, we treat that patient like a small lady, small left atrium, small area. We got the good result, but now we have the evidence to show that we can treat the patient like this. Because if you look at the inclusion criteria, if the valve area less than 4 or 3.5 would be excluded from the trial, but we treat less and less. Sometimes it's less than 3. We can treat, and you show the result with the same. Yeah, I think we found some anatomical difference from Asian and Western population, and now we have the evidence to show that we can treat the patient with a good result also. And we, in Thailand, I saw the same thing. With the G4, we use a one clip procedure, more and more, and the clip number would be like 1.2 or 1.3.
Yeah, thank you so much, Chris. So Shingo, can I ask you, since you have a huge amount of experience, Makoto showed the data regarding the mitral valve area. So we once in a while face patients with a limited mitral valve area. So how would you approach those kind of patients, and what would be your strategy to optimize the outcome?
Yes. So I think that we can treat the small valve like the less than 4 over 3.5. It's maybe at 3.0. So, but it depends on the nature or the character, the leaflet itself. So maybe the leaflet is calcified and the strict leaflet is, if the patient has some moderate MV area with calcified leaflet, maybe after one clip implantation, maybe the impregnation is higher than before, higher than usual. So I think that not only the mitral valve area, we have to think about the leaflet itself.
Mm-hmm. I think that's an excellent point. So, Paul, do you have any difficulties in your practice dealing with how much we should reduce the MR, and by not creating mitral valve stenosis? I think the valve area seems to be larger than our patients, but can you tell us a little bit about how to make an endpoint?
So there's always the dictum of do no harm, and so mitral valve area and stenosis is probably the greatest risk in terms of how we can make things worse. But it's been quite surprising when you look at like the Prime XL data, as well as your data on the valve area you just showed, about how gradients on valve areas, at least within the range that we've looked at, don't seem to have an impact on prognosis. And range meaning 4 to 7 millimeters of mercury, not 8, 9, 10, for example. And so for me, it's all about reducing the MR, and that's what the Prime XL data and other data have shown, that MR reduction is perhaps more important than the risk of stenosis, at least within the range that we've studied. Mm-hmm. The other thing that I would also just say is that in my practice, and I think in others too, we've shifted more towards morphology treatment rather than just MR treatment. So it's become more surgical-like in how we treat these valves, about getting the valve height as down as possible. Because surgeons, when they're operating and doing mitral repair, they don't have the luxury of seeing the amount of MR they're doing it. They're actually just looking at the valve and fixing what they think is anatomically important. And I think doing that, I think the results also tend to be better, because then you reduce the variability of TE versus transthoracic.
Exactly. So Paul kindly touched about the morphology and anatomy of this pathophysiology. We will move on to the great lecture we have here from Andrew Cook. So his talk would be the impact of morphology on decision making. I had a privilege to join his session in London Valves. It was really nice using the anatomical specimen, live demonstration. So I thought it would be nice to bring that format to here in Tokyo. So let's learn together.
Is it possible to perform concomitant mitral valve edge-to-edge repair with left atrial appendage occlusion? Well, of course, one requires a posterior puncture in the atrial septum, and the other, ideally, more posterior inferior, and that's because of the different orientations of the structures on the left side. So if we turn this sample over and I show you the relative positions of those from the left aspect, if we look from the other side, then here is the region of the atrial septum. My finger is in the oval fossa. So posterior puncture allows you then to steer the sheath into the mitral valve, so approach the mitral valve in the correct fashion. For the LAA, so the LAA generally sits in between the two, the upper and the lower pulmonary veins, although it can be variable in its position, so much higher really on the left atrium. And for that, we've got to torque in a different direction, of course, to reach the left atrial appendage. So I would say it's not impossible to reach both from the same septal puncture, providing, of course, the distance, the atrial septum is not too dilated. So here's a second case that we're looking from the left atrial aspect, the left side, and you can just about make out the region of the oval fossa here. So a posterior puncture would be where my my thumb is just here. And certainly it should be possible to steer the sheath into the mitral valve as we've been showing you so far, so to reach the leaflets and perform an edge-to-edge repair. Then, of course, to do the concomitant left atrial appendage occlusion, you'd have to be torquing the sheath in a different direction. So the left atrial appendage, the os is up here, and generally the left atrial appendage sits between the right upper left pulmonary vein and the lower one, which you can see just below there. And although it is variable in terms of its height, but this one is in between the two, which is quite typical. So to reach that, you'd have to torque in a different direction. So I would say it's feasible. It would be feasible to perform concomitant closure of the left atrial appendage with TEER, but that would have to be assessed carefully in each case to make sure that the location of the left atrial appendage is not too anomalous.
Okay, so we learned the anatomy, considering the simultaneous concomitant approach for left appendage closure and the MitraClip. Now we would like to invite Kent for his clinical case.
Thank you. I think Andrew has set up a very good platform to start with, mainly of concomitant MitraClip and left atrial appendage occlusion is all about the septum. And most important anatomical thing is the different direction of the target of treatment. So here's my disclosure. So I'm going to present the case first, and then we'll have some bit of a discussion. So our patient is 67-year-old gentleman with history of hypertension, atrial fibrillation. Unfortunately, he has an old ischemic stroke resulting in white ataxic hemiparesis, and also has recurrent bleeding on OAC, and recently has a left thalamic intracranial bleeding. So we have to take off his old anticoagulation. And after these two neurological insults, he has becoming quite frail, was on electronic wheelchair outdoor, but then he has suffered from 3 recurrent heart failure admission over the past year, and NT-proBNP is over 3,000. And echo shows a severe mitral regurgitation with normal LV ejection fraction. So from the screening transesophageal echocardiogram, you can see he has a very eccentric severe mitral regurgitation. From the morphology is on the lateral commissure, it seems there's a lateral commissure prolapse. So how would you treat your patient? So of course, he was only 67. So the preferred approach would probably be mitral valve repair with surgical LA closure, hopefully to take off the anticoagulation. But because of the frailty, then the subsequent post-open heart surgery recovery might be limited. So the other option would be transcatheter. Would you do a transcatheter mitral valve repair using MitraClip alone? Would you do a concomitant left atrial appendage, or would you do it on a staged manner? And the other question is, of course, would you do it like using the same transeptal puncture or using a different transeptal puncture? So this is some of the thinking process that we have. So we put this case in the heart team discussion, and our conclusion is we think this patient is having too high surgical risk because of the post-operative recovery issue. So we recommend to subject the patient on MitraClip together with a concomitant left atrial appendage occlusion, because we don't want the patient to come back for another time of operation. So as we just discussed, the transeptal puncture is actually the key for this kind of concomitant procedure. So for this lateral commissure, the height that we need from the mitral valve is not so demanding. So in this case, we actually take a 4.1 centimeter height from the mitral valve. The other important issue is, for example, if we are doing an isolated left atrial appendage occlusion, the optimal transeptal position will be an inferior posterior location. But most of the time, the posterior transeptal puncture is important. The inferior, especially in those reverse or chicken wing morphology, that will be very important. In our case, the morphology, luckily, is not very challenging, the left atrial appendage. So we actually take a mid-posterior transeptal location. For this case, I'll show the left atrial appendage morphologies later. So that's sort of like a decision based on a hybrid morphology. One is on the mitral valve morphology, which in this case is not particularly challenging. The other one is the left atrial appendage anatomy is not particularly challenging. So we decided to do using the same transeptal access. So the commissure pathology is not the main focus. I know Adam is going to show us on another challenging case, so I won't focus on that. So in this case, at the very beginning, we use an NTW grafts going to an extreme lateral. So the clip arm orientation, we at the very beginning use a 2 o'clock to 7 o'clock. Somehow, after the grasping is not sufficient reduction, you can see from the 3D multiplanar reconstruction, there's still residual MR. So we actually optimize it, move it further to lateral side, and then change the clip orientation to 1 to 8 o'clock, and actually subsequently help to eliminate all the mitral regurgitation. So that's the MR reduction. So the LA pressure also reduced from 14 to 7. In fact, you can see a little bit of residual prolapse, but minimal mitral regurgitation. So I think it's actually good for this patient. So after that, we need to move on to an appendage occlusion. So in exchange of the shift, the hemostasis is another concern. So it's a 24 French MitraClip steerable guide. We actually have to downsize to a 14 French. One of the options, of course, use a large shift to occlude that, but then we are staying away from that because most of the shift that we have is quite, we only have a limited choice of shift. We don't have the gore dry seal, so that's why we actually stay away from using the other brand of shift because that's not very helpful. So we actually use a figure of 8 suture, applied a three-way stopcock to help the hemostasis in all these cases. So this is the left atrial appendage anatomy, which is actually quite a standard anatomy, and the size is measuring 18 to 19 millimeter in the LA pressure of around 8. So we actually tend to upsize more because the LA pressure is actually quite low after the MitraClip. And we give a little bit of fluid challenge, but we don't actually do it like over aggressively. So with this 3D measurement of 17 to 19, we actually elected to either struggle between the 22 to 25, because of the LA pressure, we choose the 25. And this is the appendage occlusion procedure. You can see with this transeptal puncture, the alignment of the shift towards the left atrial appendage is actually quite optimal. It's achieving the usual weight of doing appendage closure. And this is not a particularly challenging case. We achieved the complete occlusion very quickly and a little bit overcompressed, but on tuck test it's actually pretty stable, so we think it's good. So what is rationale of doing a concomitant? So clinical perspective, AFib is very common in patients with valvular lesion, and bleeding risk in our cohort of patients are usually higher because they are frail, they are older, and LA occlusion concomitantly appear to be a good option for stroke prophylaxis. And combining these procedures would potentially be able to help you save one general anesthesia and also save you one hospitalization that has an implication on healthcare resources. And with large bore venous access, you can potentially reduce the risk of wound complication and also reduce potential complications associated with repeated transeptal access if you are doing a 2 transeptal access. And in these procedures, because we're using TEER as guidance, that would actually be favorable. So what are the evidence? So the evidence, there are actually mainly 2 published, and latest one, there's also another published publication in Jet Advance. So if we're talking about the earlier days, the MTIR with LAO, in this your intervention publication in the single center experience of 25 cases is actually quite positive, favorable successful rate. The other multi-center one is also very good. And even in our single-centered study, it's actually also only 10 cases, but it's also very high successful rate with appendage device success of 90%. The only failed case is because of the LAA size rather than the alignment itself. And in all cases, there's no significant peri-device defined by more than 3 centimeters. So to conclude, MitraClip combined with Amulet in selected MR patient with AFib and high bleeding risk appear to be an appealing option, and concomitant procedure can potentially reduce the healthcare costs and also potential complications. Thank you.
Kent, that's a really, really great. If you could just stay up there for a few questions. So So a couple of things. So in terms of anatomy, for those of us who don't do LAA closure, including me, I don't, tell us, are there differences in the morphology of appendages that make a difference as to whether or not you would choose concomitant or not? Chicken wing, broccoli, whatever?
Yes, yes. So I think the only anatomy that you would be a little bit concerned would be the chicken wing morphology, because in chicken wing morphology, most of the time you need to do a transeptal in extreme inferior and posterior in order to align the appendage from the septum. So in those cases, you might hesitate, but in most of the other anatomy, it's actually doing fine.
And does the ability to have a double curve sheath or a steerable sheath, does that influence your decision making as well?
Very, very
it's
true.
like device agnostic for LAA occlusion?
So for most of the cases, I would actually prefer to use the Amulet because the transeptal support will be more forgiving in concomitant procedure. So that's one of the consideration. The other consideration is, as you said, the steerable sheath, if we have, but we don't have it like in Hong Kong or in Asia Pacific region, that potentially will be helpful because that will actually allow you, even in a suboptimal transeptal location, the steerability of the sheath will able to help you to align well the left atrial appendage.
Yeah. How about TEE considerations? So you know, there's a pretty significant shift in practice towards a lot more ice, which may reduce esophageal injury, esophageal bleeding, and we have to think about if we have 3D probes down these elderly patients, we can increase risk of bleeding. How do you think about imaging in the procedure?
Yes, I think that's a very important point because if you have a long procedure, especially if you do this concomitant, the risk of esophageal injury might be elevated. But then it's very important to sort of standardize protocol of imaging. So we are now, because our team of imagers is very strong, we actually sort of like limit the duration of TEE manipulation. So we have to fix the amount or the frequency of getting in the probe and in and out. So when you're doing concomitant procedure, you need to do the baseline assessment at one go. And then, for example, like you do the baseline MR assessment, do the LAA sizing assessment at the very beginning, and then after the TEER procedure, and then you can directly go to the reassessment of the LAA if the LA pressure changed significantly. Otherwise, you just proceed to device implantation. That hopefully, with the standardized protocol, that you will be able to minimize the duration of repeated procedure. But then, as Paul, you just mentioned, if we're shifting left atrial appendage into eyes local guided procedure, the additional benefit of concomitant one might be reduced, but you can still use the same transeptal support.
I love the idea of concomitant because you're there. And it just makes sense. Pretty soon the EP doctors are going to be joining us in these procedures too, doing PFA. And so it's just a matter of time, right?
Yeah.
So just one technical thing. You had mentioned the figure of 8 to kind of manage the bleeding. We would just put in a dry seal because we have it. You had mentioned you don't have it.
Yeah.
But what about per closing ahead of time? Do you prefer per close or do you like the figure of 8 more?
In this setting, we used to, there are a few considerations. First, mainly it's on the cost issue because per close, that's another several hundred US dollar. So that's the main consideration. The other consideration is the figure of 8 allows you to adjust very easily. And the way we do is we use a three-way stopcock that allows you to adjust very friendly in a very friendly manner. Although I know per close, sometimes you can also tighten it, but then there's only allowing you to tighten, but then there's no way to get it loose. So that's one of the potential advantage.
We use that stopcock method for the Impala. For if you guys do Impala, it's the similar concept when you take the peel away sheath out using the stopcock. All right, so how do we get these things paid for? Who has this available to be paid? So in the US, we can't do concomitant because we can't get things paid for. Other places around the world, can you have this covered in your hospital?
So in Korea, MitraClip is not covered by insurance. So compared with the mitral TEER, it's very cheap. So concomitant is absolutely better. So I think I'm very happy to hear this case because this is what I exactly curious about. Because I have several cases. We have a lot of atrial severe functional MR. We fixed it. After fixed successfully, you can see a lot of smoke on the left atrium. And I experienced several cases about immediate after procedure. So during the what is that?
Hemostasis?
Hemostasis.
Yes, yes.
Is there's a stroke? Is developed.
Yeah.
So we really worried about immediately after procedure. There's a severe smoke, but we cannot do anything. So in those cases, I think we can do this LA appendage occlusion preventively. So do you have any idea about those, if there is severe smoke, LA function is severely decreased, after atrial function MR fixed, and then do you have any strategies to use the LA appendage occluder and for preventing stroke?
So from our experience, we mainly doing this concomitant procedure for indicated patient because, as you said, it's all about the reimbursement issue. So there's some certain limitation of the indication for appendage closure. Otherwise, the patient have to pay out of pocket. So we are doing it mainly for initial index patient that has high bleeding with, like in this case with intracranial bleeding. But you have widely pointed out after the TEER, some of the patient has smoke, but to me, I don't have an answer on that, whether the appendage closure versus anticoagulation will be an ideal option in this cohort of patient.
We actually have a paper in JACE on that very question, and the occurrence of spontaneous echo contrast was actually associated with improved survival because there was better MR reduction, but there was no penalty for adverse events. So interesting.
Of course, that is sign of the successful result.
Yeah.
But we have a lot of mitral stenosis patient. So in the severe mitral stenosis and the smoke, that's certain degree is okay. But the dramatically increased LA pressure because of the stenosis and the smoke, maybe they can cause more stroke or some clinical event.
Getting back to the reimbursement, Chris, in Thailand, what do you, is it covered?
Yeah, it's not. Both of them don't cover by insurance, but we did some combined case with the LA and MTR, but most of the time we did in the state fashion. We did only one combined, I would say like Ken is doable. We can do with the same septal, but I did differently. When we removed the guy, we put the 18 French sheet, and we did the pre-close before time, and we put the 18 French, and we tied it the pre-close, and we put the LA guide into the 18 French sheet. I think is that another option to do combine with the clean guide.
Okay,
Yeah.
so I think we had a very nice discussion regarding this topic. So thank Ken for a wonderful presentation. And I think we have solved this problem.
Very much.
So let's go for the anatomy back again before the two remaining wonderful cases. So the first talk from him would be the oval fossa anatomy.
Now let's look at the right side of the atrial septum and think where the best position would be to perform a transeptal puncture in order to be able to access the mitral valve for an edge-to-edge repair. Now, if we look at the atrial septum, of course, we have the SVC at the top, the IVC at the base. Here is the tricuspid valve and the coronary sinus just below here, separated by the eustachian ridge. So this is the inferior part of the atrial septum, superior at the top. The region towards the AV valve, closest to the AV valve, is here. And in fact, it's the posterior part of the atrial septum that's going to give you the greatest distance, the best access to the mitral valve on the other side. So let's turn this heart over and look together from the left side of the septum. I'm going to put my finger in the oval fossa here, just to show you that position. And a posterior puncture, really where that small hole is, that posterior puncture is going to give you the greatest distance, therefore, to be able to access and align the clip appropriately with respect to the mitral orifice. Let's look at that in a second heart, and this is a section that will be familiar to all. It's a 4-chamber section, and you can see here the two leaflets of the mitral valve that we're aiming to perform the edge-to-edge repair on, the posterior leaflet And here's the anterior leaflet here. And behind there, within the atrial chambers, between the atrial chambers, we can see the atrial septum. Here is the thin membranous component, that fibromuscular membrane, which is the oval fossa, little muscular component connecting it to the AV valves here. So when we're performing a posterior puncture, we're aiming to be going as posteriorly as possible within the oval fossa, and then that will give us the greatest distance to then be able to turn down, steer downwards, and align correctly with the mitral valve. If we go to posteriorly, so looking here at the posterior aspect, you can see there that there's an infolding of the atrial walls. This is what's sometimes called the secondary septum, and you can see that actually it's an infolding of the atrial walls with fatty tissue, extracardiac fatty tissue in between. So if we perforate this, if we go too posterior, then of course we risk going outside the heart and creating tamponade or a pericardial effusion. Alternatively, if we're too anterior, so we perforate the atrial septum anteriorly towards the AV valves, then of course we can get into the left atrium, but we may not have enough height or space to be able to steer downwards and get the correct approach to the mitral valve leaflets. In contrast to that, here's a much smaller oval fossa. Again, we're looking from the right atrial side, so the SVC is at the top. There's a broad rim here between the SVC and the margin of the oval fossa there. Here's the IVC rim and the AV valve rim towards this side. So they're all quite broad. And really, there's not much leeway, really, in terms of the transeptal puncture. Ideally, you want to be going posteriorly again. It's only a few millimeters before the anterior rim. But if you want to go posteriorly, you should try and remain within the oval fossa. If, of course, you're within this posterior rim, then you're within the infolding between the atrial walls, and perforation here will lead outside the heart into pericardial space.
Okay. So the next one would be how are the leaflets and the cords arranged in the heart?
Now let's focus on the leaflets and the cords. And we're looking here at the mitral valve from the atrial chambers. Clearly, this is A1 and P1. Here is A3 and P3. And let's think about the challenges that the leaflets present for both imaging and for edge-to-edge repair. So we've got a main zone of apposition between the leaflets, but clearly that's curved. And so that's a challenge for imaging, because we'll be cutting across the leaflets in different forms and different ways depending on the angle that we are actually cutting the annulus. And then, of course, for clipping, we ideally want to be perpendicular to that zone of apposition, that main zone of apposition, and that's curved. And so we need to orient our clip in different ways depending on which area of the mitral valve we are clipping. So clearly, one main zone of apposition, there are multiple folds in the posterior leaflet in particular that allow the leaflets to come together, and we'll focus on one of these in just a moment. If you think now about the cords, and we're showing you this valve now in a more anatomic fashion, what's clear is that the entire free edge of the leaflets is supported by cords. It needs to be, of course. What you'll see here is the anterior leaflet is more apron-shaped. If we just focus in on the caudal region, there is a narrow region there in between the cords arising from the two papillary muscle groups. There's this narrow region there which is generally more free of cords, although there are cords on the underside, which is amenable to clipping. So that's the anterior leaflet. You'll then see narrow regions here towards the commissures and then going into the posterior leaflet there, where there are fewer cords perhaps, and we could then clip the posterior leaflet to the anterior leaflet in that region. One thing just to note in passing is that we have cords arising from one papillary muscle supporting both leaflets, and often that's misrepresented in many of the textbooks. So you've got the papillary muscles, the papillary muscle heads, like the fingers of a hand, they're supporting these fan-shaped cords, and cords there arising from one group supporting both leaflets. And this is the more complicated commissural region of the leaflet.
Right, the next one, where are the leaflets grasped and gripped?
So we've looked at how the cords attach to the leaflets and the cord-free zones that are available for clipping. And we looked at how the leaflets join together in terms of the commissure and the challenges that present. Let's think about now how the clip will grasp the leaflets. And to do that, I've turned the anterior leaflet over to show you the underside. And if we bring a clip into the picture, you'll see that actually the arms of the clip only really reach the rough zone of the leaflet here. And you can see the grippers there that could come down onto the leaflet. There's 2 rows of that to distribute the force nice and evenly across the leaflet. But the clip needs to be designed so that the force, as it's closed, the force is nice and even across this thicker region of the leaflet. And then all of the leaflet will be grasped in an equal fashion.
And next, the clefts, what are they and what should we call them?
Now, there's been a lot of discussion about clefts in the mitral valve. And if we were talking about a true cleft, a congenital cleft in the mitral valve, then of course it would be in this region here, in the midpoint of the anterior leaflet and pointing towards the aortic valve. But in relation to edge-to-edge repair, people have been talking about spaces within the posterior leaflet, so effectively accentuated folds within the posterior leaflet, and calling these clefts. Now, admittedly, from above, if you look at this space here, it does look like a division between the leaflet tissue that runs all the way to the annulus. But in fact, that's just an accentuation of the normal folds within the leaflet. You can see there's thin leaflet tissue running underneath that's supported by cords. And it's created by a hooding and a thickening of the leaflet tissue on either side. So that creates this potential division, and you may well get regurgitation through this region, of course. Now, people aren't clipping this region, so edge repair of this region, but these can be important because if you place a clip adjacent to that, then of course you can pull this region apart further, and then of course you may have additional regurgitation or increased regurgitation through this region. So undoubtedly they're important with respect to edge repair, but I would term these accentuated folds. I'd like to show you the same thing in a second heart, which we've opened out in anatomic fashion this time, of course. And this is the accentuated fold that we were just seeing in the similar thing as just seeing the other heart. Now what you can see on either side of that fold, we've got thickened leaflet tissue, which is slightly hooded. Let's say that's an acquired process. But this is really an accentuated fold that's supported by thin leaflet tissue in between. So when we look from above, it looks like a complete division. But as we open this out, you'll see there are cords and a leaflet tissue in between that supposed accentuated fold. If we had a true cleft, of course, it would be within the anterior leaflet of the valve, so in this region here.
So what's the valves should we avoid for the transcatheter edge-to-edge repair?
So what sort of valves should we avoid with edge-to-edge repair? Well, clearly this is a good example. We've got stenosis and regurgitation across this valve. The leaflets aren't able to coapt together successfully, and you've got marked dilatation of the left atrium in addition. So if we look at that in more detail, you can see the leaflet tissues are not able to coapt together, not able to join together. The leaflet tissue is very thickened and stiff, and also are not able to open properly. And essentially, we've lost all of those folds within the posterior leaflet here, and that's resulted in the stenosis. So definitely a case to avoid with edge-to-edge repair. Here you can.
Okay, so much to learn from this anatomy. Always whenever I see his lecture, there's so much to learn. We learned how to puncture appropriately, more posterior, but still in the fossa. And we learned about the leaflet and the subvalvular structure. So we would like to go for the, okay, this one will be the, the next clinical case would be the Adams case regarding the commissure lesion, dealing with A3P3 lesion. So we will appreciate his talk regarding this commissure lesions.
Let's think together what we need to consider if we're clipping in a commissural region. Now, clearly, this is a complex region in terms of caudal anatomy. We've got cords fanning out from one papillary muscle head here and supporting both leaflets of the mitral valve, so both the anterior and the posterior leaflet. So this is the region of P3 and A3, but also we've got a similar sort of anatomy at the top here at A1 and P1. Again, you've got these fan-shaped cords coming out and supporting both leaflets. So clearly the key is to make sure that you've got the correct orientation of the clip before you cross the leaflets. If we go across the leaflets and then try and reorient the clip, clearly we risk getting caught within these complicated fan-shaped cords. So correct orientation before you cross the commissural lesions, of course, is the key.
Okay, so we understand quite well the structure of the commissural part, and now we'd like to invite Adam for his clinical case. I think this one, right?
And following, I think Andrew has already, visualized and also strengthened our understanding, background understanding about the commissure pathology, commissure anatomy. That it looks much more than what we can see from the echo images. So this is our case, 92 years old gentleman, and has hypertension, a chronic lung disease, and he was also a heavy smoker. He actually presented to the other hospital due to the inferior ST elevation myocardial infarction complicated with cardiogenic shock, and followed by respiratory failure in 2 days after the primary PCI. And he was referred to our hospital because severe MR was noted by the echo images in a month, after 1 month intubation. So it's quite fair. The X-ray and also CT showing that the patient really was in bad conditions. So this is the image showing that the patient had medial commissure mitral regurgitation. From the 3D unforced view, nicely showing that the patient had flare medial commissure leaflet and with very severe mitral regurgitation. So which many arising from the medial segment. But when we have a beta bicommissure, we also showing that the patient might not only have a medial commissure MR, but also have central, it should be related, central functional MR. We can see on the right-hand side, the vena contracta is quite centric jet. So given that the patient might have two volume overload related central function MR. So given that a general concept, when we treat in the commissure, the function MR could be also resolved after the treatment, successful treatment. So we have to, for the commissure pathology, we have nicely looking into the, including the leaflet length and also the subvalvular space. From the right-hand side, it's nicely showing that if we treated this patient, even the patient have very long, lengthy leaflet, the long clip might not able to really can, dive into the ventricle without kissing on the ventricular wall, which might also irritate the ventricle and also, initiate a ventricular ectopic rhythm and further increase the risk of caudal entanglement. And we can, of course, we need to get the understanding of the leaflet length, which is 9, so it should also suitable for the show clip. So for the in summary of this patient, 92 years old gentleman, recent myocardial infarction and cardiogenic shock, has severe mitral regurgitation and commissure pathology, replay failure, and also acute renal failure. The NT-proBNP over 60,000, and also the patient have very poor renal function with high BUN, creatinine, and also high sodium, which suggested that the patient, the prior heart team actually is quite aggressive to diuresis the patient. The invasive hemodynamic also showing that the patient have high wedge pressure, of course, and high mean pulmonary pressure, and also high right atrium pressure, which might, and also PVR, which might related to the poor lung condition, or chronic lung, may also related to the chronic lung situation. So for, just as Andrew said, that when we treat we decided to use the show clip clip, which might allow us more precise, manipulation on the clip. And we have, the most important is that you need to have a very good orientation, and try to keep the orientation dive into the left ventricle, and then you open clip. You can nicely see that from the longitudinal long axis view, showing that when you open the clip, given that the commissure lesion, the AP diameter would be quite short. So when you even use a very short clip, when you open the clip, you can nicely see that you have, the both clip arm touch to the annulus, and also whenever what you have leaflet tissue on your clip arm, when you close it, you would have everything. So after a single clip, we have nicely reduced the mitral regurgitation to mild or mild to moderate. But we can see that the adjacent to the first clip, we somewhat see remain residual collapse. So at that time, we have pressure gradient of 2, and therefore we go for the second clip directly, and which is very quite easy after for you to introduce a second clip. You parallel to the first one, and then you can get a very nice grasp. So after 2 clip devices, we can achieve a mild, trivial, or even zero mitral regurgitation. And given before the procedure, we already have known that the patient have severe elevated right atrium pressure. So before we saw the catheter, we already seen that the patient have significant bidirectional shunt. So after we saw the system on the right-hand side, we can see that the patient actually have bidirectional shunt and more from right side to left side. And therefore, the patient have desaturation. So we have keep observation for 10 minutes, but the patient still have desaturation status. So therefore, we go for direct occlusion of the atrioventricular atrial septal defect. And given that the patient has already was already been in very frail condition, so we hope that the management can improve and facilitate the recovery process. So after the procedure, the patient can the IVP can be removed in 2 days, and the patient was put on hemodialysis. But after 1 week, the patient had get fully recovered in renal function. The creatinine returned to less than 1. And given the patient has been put on intubation for more than 1 month, so he was too fragile to get wind from the ventilator. So he received a tracheostomy in 2 weeks, and then discharged home smoothly. So this is the 3 months follow-up echo showing that we have a very durable effect, that the patient have zero or trivial mitral regurgitation. This is the very nice paper published from Cedars-Sinai, probably the first paper to addressing the prevalence of the right to left shunt after a mitral TEER procedure. Consecutive, more than 300 patients, 20 of them, which is 5%, have right to left shunt. And 1/3 of them, which is 7 patients, have desaturation and warrant immediate occlusion of the atrioventricular septal defect. So and those patients who have developed right to left shunt have worse renal function, higher BNP, and more severe and more frequent severe MR, and also have higher right atrium pressure, mean pulmonary artery pressure, and higher PVR before the procedure compared to those without right to left shunt. So during the follow-up, the patient with right to left shunt have more frequently have desaturation, and also myocardial infarction, mortality, heart failure, hospitalization. So, given those patients might have long-term more fragile or even worse hemodynamics, so they would have or condition other than heart for similar as what our patient we said have lung disease. So who would get a significant right to left shunt? We found the right-hand side, the invasive study also nice showing that for those patients who has even more dramatic reduction in LA pressure, either in V wave or in LA mean pressure, you would have right to left shunt. So, which means that even you have very good reduction in mitral disease, some patients might have right to left shunt due to the other reason. So in conclusion, for patients with severe primary mitral regurgitation and for prohibited surgical risk, I believe that mitral TEER could be the last resort to have tidy life-saving procedure. And remember to check the intra-atrial shunting after the procedure, given that it might jeopardize the recovery process after the procedure. Thank you.
Thank you, Adam, for sharing extremely challenging case, both anatomically and clinically. But you really managed really well. Congratulations. So I would like to ask the panel if you have done a little bit differently for this specific patient in terms of the clip strategy or the overall clinical management, KK?
Well, I think Adam did a tremendous, it's a very amazing result and got the patient out 92 years old. I'm sure he went back to smoking. But really amazing results. I guess the question that I have is that I think there was probably a torn, partial papillary or whatever torn, and I think he managed to grab that. So the question I have really relates to, in that setting, it is capturing the torn cord or partial papillary muscle, whatever, that made a difference. But in true commissural prolapse, the direction of the clip is a challenge. And I still have a headache when I look at those cases because sometimes it's really hard to tease out what direction. So in this case, specific to your question, Yohei, I think I would have done like Adam did. I just don't know whether I've gotten as good as result. But I was just looking back at earlier talk by Andrew and in the context of Adam's talk, what should our thinking be with the commissural tongue sticking out, whether we should make it, in what direction should we put the clip. So I'd like to hear the rest of the panel's thoughts. Thanks.
Paul, any insights?
Yeah, so I'm really glad you brought up the papillary muscle partial rupture. We have treated 12 patients like this. The first thing I'd recommend from anybody who has a MitraClip program is that if one is going to do these cases, that you let everybody know this is a salvage case, because this patient is extremely high risk and very high chance of dying no matter what procedure result you would get. 92-year-old biventricular failure with shock and in-organ damage, it's all the boxes.
Exactly.
So I would let everybody know that this is a complete salvage case from a program standpoint. From a technical standpoint, when we treated these papillary muscle ruptures, the key, in my opinion, is to make sure the papillary muscle head ends up on the LV side. And sometimes it's just really hard. We've had patients where there's so much tachycardia that the papillary muscle is essentially sitting in the left atrium, and it's very hard to get it to fall down. And in those cases, the MR result is not as good. But if you can get the papillary muscle to come on the LV side, I think you'll get a really good result. We've used adenosine to help make sure it gets on the LV side, so just a technical standpoint. The only other thing I would say is that in the commissures, because the papillary muscle is ruptured, you don't need to worry about chordal entanglement. You can take the biggest device, there are no cords, they're just flopping everywhere. And so you can take an XCW and you can pull down more. I think what you did there with 2 smaller devices is perfect in itself. So it's a great result, yeah.
Thanks, Paul. Professor Hong?
Yeah, I agree with Paul because this patient is papillary rupture. So I don't think there's a risk of the chordate entanglement. So it's a very easier step. So I just want to ask about why you wait so long, 1 month? Because this patient is acute severe MR due to papillary rupture. So if you did an immediate after you find severe MR, that it's easier and you can save the life. And you don't need to fix ASD, I think.
Yes, that's true, because the patient actually is referred to our hospital after 1 month after his cardiogenic shock. And to me, actually, I do the primary mitral TEER because I'm out, when he referred to my hospital, I'm outside my city. And when I return, the surgeon told me that you have to do the procedure immediately after you return the hospital. He already prepared everything. So it's me to return the city. Within an hour, I jump into the cath lab, and after 1 hour, I leave the cath. So
yes.
I did the primary mitral TEER, but the patient referred to later.
In terms of in the imaging cardiologist perspective, we should fix this kind of pathology as soon as possible.
Sure,
if you find chordate rupture and acute severe MR, time is very important.
Thank you. So final technical question to you, Adam, is that since KK raised a very nice point of orientation of the clip, so obviously the second clip had impact based on the first clip direction, orientation. So looking at the final 3D image, the second clip, did you grasp A2 and P3?
No, actually it's remain A3 and P3. So usually when I introduce a second clip, I would parallel, given that from I did not show flow image, the clip is quite close, it's side by side. So when you have side by side, given the first clip, we potentially change the cooptation what we before before the procedure. So I would usually to side by side. When we do the side by side clipping, I would parallel the second clip to the first one. That would be quite easy, and you would be much easier to get positive there. And regarding the commissure, papillary muscle rupture, but given that when we still see the subvalvular, subannular the space, because space is not really sufficient for a long clip, because when you advance a long clip into the commissure, you probably will hit on the left ventricle before you open the clip. Yes. So for that reason, I usually would have short clip, especially anti-clip. We also, from the anatomy, showing that there are numbers coded. So the code between coded space might not really, sometimes might not sufficient, might not wide enough for a wide clip. So for the commissure pathology, I usually have anti-short clip. And just echo, Paul has already proposed a very good point. When you open the clip, because the AP diameter is quite short at the commissure part, when you open it, with both arms already exceeds the both annulus. So when whatever you have onto your clip, you just lower your gripper, in cross it, you would have everything. So that's why I learn from the previous experience. When we even have very short NT, if you get the right position really at a commissure, and you will have everything. Yeah. The other thing, the other point I would mention in the technique part is that when you dive into would I go for the even more commissure? Do not talk to the posterior. When you talk to the posterior, we know the commissure is a bit anterior, not posterior. So sometimes, especially when we're treating the lateral commissure, when we talk posterior, you go medial. So we get you a device away from the commissure. So in that situation, just maintain maybe the trajectory during when you introduce, you already have a good trajectory. And the other thing is that for the central, I very appreciate and also agree that the adenosine could be very useful, but we also have some experience that even patient had cardiogenic shock, central chordate rupture involving very broad jet, cardiogenic shock, put on ECMO. Even when we introduced adenosine, it did not really get everything. And most commonly is that we would have caudal, the cord will, flick to the left atrium and entangle your gripper, and you will not really to cross it. So in that situation, when we have central large pubic muscle rupture, I will fully open. You use the long arm clip, of course. I will fully open. Try to, before I dive into the left ventricle, the muscle will not, jump into the left atrium. Just what Paul said, you have to better to maintain the pubic muscle inside the left ventricle. So you have to fully open your clip and you dive into the left ventricle, and you will have chance that not allow you before you get the leaflet, and before the pubic muscle jump into the left atrium, you already get a leaflet.
All right, thank you, Adam. Thank you so much for sharing your great experience. Before Shunsuke's case, we'd like to go over the morphology, talking about the restriction of the posterior leaflet for this specific case.
What do we need to consider then if the posterior leaflet is very restricted? So that might be for various reasons. It could be due to gross left atrial dilatation because of atrial fibrillation, or as in this case, the posterior leaflet is restricted in motion because of an extensive myocardial infarction. If you look at this heart at the below, you can see that there's myocardial infarction with a thrombus sort of filling that aneurysmal pouch there. And so you can get restricted motion for lots of different reasons, mitral annular calcification, for example. So what we need to consider is that the leaflet, posterior leaflet, is restricted. The anterior leaflet will then try to meet that in order to coapt together. So the leaflets try to coapt, and therefore there's more tension potentially on the anterior leaflet, which is more stretched. And that, of course, can, if you're clipping these leaflets, can lead to additional stress on the leaflet. So obviously be careful. You've got to be careful not to tear the leaflet, and you might want to consider which type of clip then that you use to perform edge-to-edge repair in this situation.
Okay, so now let's see how Shunsuke overcome this challenge. Shunsuke?
Thank you, Hayes, for the kind introduction. So I'd like to share the functional MR case. So the previous cases are degenerative MR cases. So the patient is 79 years old lady who have a history of cardiac sarcoidosis and congestive heart failure. So she was very small and a little bit frail. So despite the almost optimal medical therapy, she has still asymptomatic with NYHA class 3. And also he had a history of paroxysmal AFib. So when we look at the chest X-ray, you can see some lung congestion. So in the ECG, you can see a very narrow QRS, not indicated CRT. Okay. So this is a TTE. So the EF is reduced to 34%. So LV was not so dilated, but you can see some CBI more. But it's separated, a little bit seems separated between the lateral and the medial purge. So EROA was 0.42, indicating the CBI more, and he had also the pulmonary hypertension. So this is 3DT, you can see a separate jet. So lateral jet and the medial jet. So as you can see, the lateral jet looks more greater compared to the medial jet. So this is a biplane image. It's a X-plane image A3P3, not A3, medial A2P2. Here you can see some MR, eccentric MR. Here is a central A2P2, but you can see a tiny MR. Here is a lateral A2P2. You can see a huge MR. But imaging is very challenging, as you can see. The posterior leaflet is not so well visualized. And it's due to the, I think, cardiac sarcoidosis. There is some asymmetric tethering. And the length of the posterior leaflet is very unclear. So this is a measurement by my echocardiographer. So it's a central rate P2. You can see the like around 8 millimeter. Oh, so this lateral rate P2 more unclear. So it looks 6 or 7 millimeter. So what is the strategy? So which clip do you use in this particular patient? So CVMR with the 2 separate jets, because I think a lateral MR is bigger than medial. And there is you can see the rich code here, and it is where the leaflet length is unclear. So we can choose among four different clip sizes. So who will use the NT clip? NT? No, nothing? So who will use the NTW? NTW, most of the half of them. So XT. I think not, no, yeah, I agree. Who will use the XCW? XCW, no. I think all attendees will use the NTW, right? Okay. Who will go to surgery? No, nothing? Okay. Okay, so yes, I agree that. This is my plan, so I will choose the NTW. And the first target is, as you can see, is a lateral P2. After that, I will consider to put the additional clip. I think using NTW and NT for the medial P2. So this is my actual strategy. So this is transseptal puncture. It's a very straightforward transseptal puncture. But as you can see, my target is a lateral P2. So, but as you can see, these foci are located in the relatively inferior part of the septum. So I accept the superior puncture. So superior or posterior puncture. So because if we puncture the inferior, it's going to be very challenging because I think the posterior anterior dive will be posterior to anterior dive trajectory will be expected. So the height is enough. So the 40 millimeter from the angle. I think 40 millimeter is enough in the tethering cases. So this is the clip trajectory. So as you can see, the posterior leaflet are like this. So it looks like a car. So I think that we have to avoid the anterior dive trajectory. So we have to avoid this trajectory. So we have to go like this. So when we see the clip go like this, we have to put a minus node in this particular cases. And also in this case, we will go to a lateral P2. So I think 6 o'clock the perpendicularity is, I think, good, but a little bit clockwise. Clockwise trajectory will be acceptable in this particular case. So we confirmed the clip position in the LV. I think there is some MR here, but I think this here is some cord here, so I think this position is not so bad. And in the 3D image, so it seems it looks a good trajectory. So we try to grasp the leaflet. So, but as you can see, it's a very challenging posterior leaflet length visualization. So I try to drop the gripper down simultaneously for anterior posterior leaflet. How about this grasping? So is it okay or not? Is it okay? No. Yes, so this is not so okay because it's curved. And I think ideally the gripper touch right here, so almost at the angles. Ideally, so I want to see the gripper like that. So de-grasping. So I apply the independent grasping in particular cases. I firstly grasp the anterior leaflet first, and then we turn the guide clockwise to capture the posterior leaflet like that. How about this grasping? Good. So it's, I think, ideal grasping. I think a little bit we can see a cord here, but if the leaflet inserted between the gripper and the arm, so we can close the clip and we can see the restrictive posterior leaflet. So we close the clip. So when we close the clip in this case, we have to take care here. So if we grasp the leaflet, so leaflet going toward to the shaft. So we have to see here, and after closing, we have to check the color Doppler. So as you can see, the lateral MR is almost completely disappeared. So it looks a mild MR. So we need a second clip for medial MR. No, I stopped the procedure here because hemodynamic is improved and the mild MR, and also here you can see the medial MR a little bit far from the first NTW. So when we try to cover this MR, there is some gap here. I don't like this, so I finished the procedure here. But this is looks like a complex procedure, but the procedure time only 50 minutes in this particular case. So this is 6 months follow-up. So still mild MR. So BNP levels are still high, but decreased. The lung congestion is improved despite the same medical therapy. The pulmonary hypertension also improved. So in this case, so we sometimes see a secondary MR associated with a cardiac sarcoidosis. As you experience, the case leaflet morphology of the cardiac sarcoidosis is a little bit tricky. These cases are other sarcoidosis cases, but in both cases, the posterior leaflet is very restrictive and difficult to see the difficult to visualize in the TEE. But recently, Mike and colleagues published the efficacy of the TEER for the cardiac sarcoidosis from the Ocean Mitral Registry. So as you can see, despite the tricky anatomy of the cardiac sarcoidosis, procedure success at 100% and no SLDA and leaflet tear. But as you can see, MR grade is not so optimal because more than about half of the patient has still a moderate MR at 1 year. But when we look at the NYHA class, most of the cases heart failure symptoms are improved at 1 year. So I think the TEER is effective to reduce MR and improve the clinical outcome in these subsets. In summary, so our case had 2 separate jets with a restrictive posterior leaflet. And I think optimal leaflet insertion to reduce MR dramatically. So cardiac sarcoidosis often has a restrictive posterior leaflet with asymmetric tethering, but TEER is effective to improve the MR symptoms. Thank you for your attention.
That was a great case. What I really like in your discussion was orienting the clip trajectory relative to the posterior leaflet and the coaptation zone. A lot of times, depending on how the leaflet's tethered, it's hard to get the device under the free edge of the posterior leaflet. And sometimes we need that aorta hugger, as you're saying, adding minus, or sometime a different transeptal, but to get that free edge under there. How often are you adding minus to kind of match the posterior leaflet?
Thank you, Paul. So I think that the symmetric tethering, we don't need to put the minus knob.
Yes.
But I think that in the asymmetric tethering, so we have to insert the arm between the posterior and the posterior leaflet and the posterior wall like that. So that's why I think depend on the position of the transseptal puncture. But I think that if we puncture the mid or inferior, we have to put the minus novi.
Yeah. For those of you who have tricuspid experience or looking at tricuspid, it's the same that goes for the septal leaflet, because the septal leaflet's always curled, or almost always. You have to create that trajectory. I want to ask the panel about this case, because this is a case where there's very little leaflet tissue. So you have very little to work with, which means that sometimes when we put the first device, it makes things worse. I have a certain strategy that I've changed to, where I tend to go right down the middle first, because I think that creates the most coaptation for what little tissue you have. Here you went just a little bit lateral, thinking you might need 2 clips, but you actually pulled it together quite a way. When you have a broad jet, let's just say there's atrioFMR or deficient posterior leaflet tissue, where do you put the first clip? KK, you want to start?
Pretty much I do what you suggest and then get a sense of whether I need to shift the clip medial or lateral. For atrioFMR, I think typically you need more than 1 clip just for that support, especially if you're worried about leaflet tear. So if I see that the jet is split more on one side, I'll just make sure I bias the other side so that I can put a second clip.
But you try down the middle first?
Yeah.
And just see what happens. Dr. Hong?
Yes, we sometimes encounter a case with the mitral regurgitation is originate from the 2 sides. So the first, if the clip is implanted in the center of the mitral clip, I think the residual MR are moderate and from the 2 sides. So I think that usually we usually have to implant the first clip to the lateral or medial side of the center.
Yeah. So you think positioning it a little bit more, Chris?
Yeah. I think, congratulations, Kubo. I think this is a very good demonstration to treat the functional MR from the restriction of the posterior leaflets, that different from the atrial FMR. For the functional MR like this, sometimes you can be surprised if before the posterior you can see the jet form everywhere. If you just put those 1 clip at the middle, then bring the posterior leaflet up to create the coaptation line, the MI is gone, just 1 clip. That can be surprised. I would start from the middle of the valve also.
Try it down
with
the
this
middle.
case.
Yeah. Dr. Hong?
Yes, I think this case is a little bit different from the classic atrial functional MR because of the atrial fibrillation, because this patient have sarcoidosis. So this patient have a certain point of the ventricular point. So I really want to, if the posterior leaflet tissue is very small and a very wide jet, I agree with you, Paul's strategies. Central clip, bigger one, and the lateral medial second clip. But this patient, I will follow Kubo's strategy.
After looking at the result.
It's a great result. I think, I think we're at the end of time. Shall I do a summary? So
please summarize what we learned today.
Sure. So thank you all for being here. It was really just a wonderful session. We covered a lot of great anatomical correlations with what we do in terms of transeptal, where to puncture, whether you're doing an LAAO at the same time or not. We also talked about leaflet anatomy and placement of the cords and making sure the device is oriented well. We had great cases talking about how to treat commissures as well as papillary muscle rupture or acute MI and cardiogenic shock, and that was a great case of how to manage somebody with a posterior leaflet tissue. So it was a great session, Yohei. Thank you so much.
Thank you so much, Paul, for your great summaries.